will be displaying that, sir.
Hello.
Hello.
Yeah. Hi, Bhavesh.
Yeah. So we'll be displaying the slide.
Okay.
Yeah. So yeah. Bhavesh will display the slide, Datta.
Okay.
So
Okay. Fine.
You can utilize the visual.
Fine.
And then Karan's going to talk about COMISA, and let him take his time. We've got enough time today.
Yeah.
And once he's done, then I have 11 slides for a case, out of which the case is 5 or 6 slides and 3-4 slides to illustrate what went wrong there. It's very brief. There's nothing. It's 20:02, so maybe we will give it 6-7 minutes and then.
Yeah, maybe 5 minutes and we'll start.
Yeah. I also send it to the somnologist group, but I think it's for most urologists, 8 o'clock is too early, and that's kind of a verdict on how we are working. And, yeah, I have neurology colleagues who see patients at 2 a.m. in the morning.
Yeah, I think it's coming down rare. There are only few now. Most of this younger generation now winding up quite early.
I leave at 6:30. 6:30, I'm out of the clinic.
Yeah. As you become more senior, you tend to do it much faster because other things become more important.
Yeah. So I was looking at a slide which one of my classmates sent me from medical school, that the older you get and the more life you have seen, you're more careful about your life ahead.
Yeah.
Which is true.
Hello, Dr. Karan. How are you?
Good, sir. I think we haven't met, but
yeah. We met only on WhatsApp.
Yeah.
So Karan's in Surat, and
yeah,
he has his own sleep lab. So
So most of my energy burnt counseling has been with this COMISA patient, because you first deliver the OSA diagnosis and then you realize, oh, it was a mistake. Should have done it the other way around. So stressful.
But this situation is more common. Patients being treated for insomnia for years together.
Oh, all my geriatric patients, who come and say, Doc, we can't sleep.
Exactly. This
70% or 80% of them have undiagnosed sleep disordered breathing.
Yeah. And most of them will be on non-benzodiazepine receptor agonists.
Oh, absolutely.
Yeah, most of them. And then worsens and then come with more and more symptoms.
Absolutely.
I think this is, I think we should start now.
Yeah, it's 20:05. So yes, the stage is all yours.
Yeah. Good evening, everyone. Today I want to bring attention to an important and often underdiagnosed condition, COMISA, which stands for comorbid insomnia and sleep apnea. Am I audible?
Yes, you're audible.
Yeah.
Maybe. Yeah.
Actually, what happens, we often think of insomnia and obstructive sleep apnea as a separate sleep disorders. But the research increasingly showing that the significant number of people suffer from both simultaneously. And that overlap is what we call as COMISA. To put in perspective, if you really go into the statistics of these conditions, about 30% of the general population reports symptoms of insomnia, and about 10 to 30%, depending upon the population, will have an incidence of obstructive sleep apnea. But what is surprising is around 30 to 50% of the people with OSA also experience chronic insomnia symptoms. And conversely, about 30 to 40% of the patients with insomnia may have underdiagnosed OSA. This bidirectional overlap is more than statistical, meaning it has a real clinical consequences. How it makes a difference is insomnia symptoms usually reduce the CPAP adherence, which compromises the OSA treatment. At the same time, repeated apneas and arousals worsen the sleep continuity and make insomnia more persistent. So the result, what happens? These people, COMISA, will tend to have a more mood disturbances, more cardiovascular risk, and more pronounced daytime fatigue and impairment than those with either condition alone. What this means for us is that we must identify COMISA early. Treating only one disorder often leads to a suboptimal result. So for any patient presenting with insomnia or OSA, we should screen for both and adopt a dual treatment approach when needed. Dr. Karan will definitely explore how to better identify and manage COMISA in our clinical practice. So can I have Karan's slide? Yeah. Karan Desai. Dr. Karan Desai is a qualified neurologist and fellow in epilepsy. And presently he is at Prashanti Neurology and Electrophysiology Clinic, SIDS Hospital, Surat. And his area of specialization is epilepsy and sleep medicine, neuroelectrophysiology, neuromuscular disorders, functional neurology, now and clinical neurogenetics and rare neurological disorders. He is a qualified registered polysomnographic technology as in from American Academy of Sleep Medicine. And he also awarded by World Sleep Society as International Sleep Specialist in 2024. And he is a member of IN, Indian Epilepsy Society, Indian Medical Association, American Academy of Neurology, MDSI, ISSR, and World Sleep Society. Here, Dr. Karan, for us to give more insight into what is COMISA, how to manage, and how to suspect and how to manage COMISA in clinical practice. So welcome, Dr. Karan.
Thank you, sir. I think this was a very generous introduction. Most of it was done by the backend team. Shall I share my slides?
Yes.
Right. Are my slides visible?
Yes, yes.
Yes, Karan, they are visible. I think you should use slideshow.
Yeah, I'll just. Yeah, all right. Good evening, esteemed colleagues and my friends. So Dr. Datta had said a brief introduction about the topic at hand tonight. So, yeah, COMISA is a combination of chronic insomnia and obstructive sleep apnea, both of which occurring together at the same time in a patient. Uh, Chronic insomnia, as we know, is a disorder of difficulty in falling asleep, staying asleep, or experiencing a non-restorative sleep, which occurs at least thrice a week for 3 months or more, and it is not solely explained by any other disorder, sleep disorder or medical disorder. And OSA, as we know, is a sleep-related breathing disorder where there are episodes of complete or partial airway collapse leading to a disruptive sleep arousal mechanism. Now, there is a lot of prevalence data when it comes to COMISA. So, like Dr. Datta also said, this is the most uh, popular paper by the Alexander Sweetman group. Actually, they coined the term back in 2017, and there is a lot of overlap. So, a lot of patients with chronic insomnia, up to 30-40%, do fulfill criteria for OSA, and similar incidence of insomnia in patients with chronic OSA. When it comes to symptoms, again, a lot of shared features. So frequent awakenings, non-restorative sleep, daytime impairments like fatigue, poor mood, sleepiness, and overall reduced quality of life. Now, we all know the unique symptoms. This august audience need not talk about the unique symptoms, but I'll spend a few more slides on the pathophysiology. And there is now robust evidence that either of the primary disorder eventually exacerbates the other one. So there is evidence that OSA exacerbates insomnia. Not only does it exacerbate, but it has causal effects as well. And similarly, insomnia exacerbates OSA. I'll talk a lot about it in this slide because it has a pictorial representation. So, uh, some patients start their journey with the initial insomnia cycle where uh, the classical precipitating factors, it could be an acute stressor, any sudden lifestyle change, stress, physical injury. It can initially trigger a poor sleep quality in terms of sleep initiation. And whenever there is a perpetuating factor, it leads to a hyperarousal response, eventually causing fragmentation of sleep, reduced duration, and some amount of circadian misalignment. Now, this subsequently leads to a poor sleep architecture. There is robust data that chronic insomnia patients actually have a altered upper airway muscular tone and an altered response to hypercapnia and hypoxia. And subsequently, there is a maladaptive behavior, lifestyle changes, which can eventually cause weight gain. Uh, Now, some of these individuals also have compromised airway. Could be either poor upper airway response, a different loop gain, and most of these individuals end up having a reduced arousal threshold. So these are endophenotypes of OSA. So whichever endophenotype this insomnia patient has, it will eventually decompensate to have frank collapses. And now these airway collapses also cause frequent arousals, awakenings, altered sleep architecture, and all the classical daytime symptoms. Now, these arousal awakenings are not always continuous. They are usually discontinuous, but over a period of time, it leads to an altered sense of awakening. So any patient who walks in with an history of frequent arousal, even if they are educated doctors, they would not easily associate it with obstructions. So most OSA patients also have an element of sleep state misperception. Initial arousals are often attributed cognitively to environmental factors, anxiety factors, all the classical insomnia perpetuating factors. So it is quite late into the diagnostic process that an OSA etiology is actually suspected. So usually the journey starts either on the insomnia side, depending on where you practice. So I practice with fellow psychiatrists. So I see a lot of patients who start their journey with acute insomnia. There is a classical precipitant. They do well with sedatives, even antidepressant, depending on their comorbidity, and eventually, because of all the maladaptive coping mechanisms, lifestyle issues, they do end up putting a lot of weight. Some weight gain is because of the pills, and then depending on their OSA phenotype, it usually decompensates, and then they have symptoms of all the classical daytime symptoms, mostly blamed on the sedatives. So this is how most patients I see enter into this journey, but the other way around is also well known. So obstructions, not frank gasping or choking, which is rare in OSA, eventually leads to this sleep state misperception, and then eventually the lifestyle issues take over. So it could start in either direction, but as Dr. Datta also said, there is a strong bi-directional relationship. Now, this is a very nice way of putting the similar points across. So, a normal patient would have a very rapid transition to stable sleep, and their ventilation usually remains stable throughout the night. Someone with just insomnia, primary insomnia, would struggle to transition into a stable sleep, but because they do not have any ventilatory issue, their sleep stage is maintained. In OSA, that transitioning is not an issue, but because of airway obstruction, there are frequent arousals. Some of them eventually cross the arousal threshold and it leads to frequent arousal events, leading to a poor perception of sleep continuity as well as eventual daytime symptoms. So, unfortunately, those with COMISA have it both ways. They have a very difficult transition into a natural sleep stage because of underlying hyperarousal mechanisms, and because of the ventilatory issues, they have a lot of awakenings. most of these have a lower arousal threshold as well. I'll talk about arousal threshold as I think it is the key crux when it comes to these patients. So this sleep state misperception actually occurs in both patients. So it is ultimately a human being's subjective sense about how his or her sleep architecture is. So any primary etiology which causes multiple awakenings, they are eventually interpreted as a more prolonged version of sleep awakening, vaso, which is wake after sleep onset. And these are then eventually interpreted as continued wakefulness rather than discrete awakenings from sleep. So this underestimation usually perpetuates. It is the perpetuating cause of chronic insomnia, and it usually leads to maladaptive coping mechanisms like uh, addictions, nicotine, any stimulants, or so on. Now, this was a very nice paper by an Indian group where they highlighted that sleep state misperception is common in both the patients, OSA as well as chronic insomnia. But this paper had a higher incidence of COMISA in OSA patients. So I'll move on to the diagnosis part. Now, unfortunately, when the patient comes to the clinic, they already have a bias about what they think is the problem. So some may spend a lot more stress on daytime symptoms, and that usually triggers us to think more along the lines of OSA. Some who have a more stress on sleep maintenance issues, especially sleep initiation, our thought process is geared more towards a primary insomnia etiology. So I usually screen very aggressively for the insomnia severity index. Now, doing a detailed insomnia scale is always difficult because of the uh, time it takes. But most patients who have sleep initiation issues, I automatically assume that there is an issue with arousal threshold because most of them are chronic insomnia patients. If there is any acute precipitant, then it would make sense to focus on just insomnia. Now, whoever has a maintenance issue, I order a sleep study very early into the journey because uh, polysomnography usually helps us be objective about the arousal threshold, and I'll talk a bit about it. You unfortunately would struggle to get these COMISA patients into a sleep lab. So, although a level 1 sleep study would be gold standard, a lot of patients are now comfortable with a level 2 study at home. I am not very experienced with those home test devices because their ability to pick out this arousal related hypopnea. So the AASM definition says that whenever there is a 30% drop in the flow, airway flow, and if there is an associated arousal on EEG, it is counted as a hypopnea. So this arousal related hypopnea usually is missed by those level 4 or PAT devices. So I prefer to do a level 2 home study where they are comfortable in their home, and it gives a very good idea about their endophenotype, which helps me plan their long-term treatment. So wherever there is a sleep initiation issue, I do an ISI. Whenever there is always a maintenance issue and classical daytime symptoms, I usually start with just a polysomnography and then dig deeper about possible perpetuating causes for insomnia. And obviously, you do need your psychiatrist, your psychologist. For the odd patient, you need a pulmonologist. And the PSG findings are, as expected, a reduced total sleep time, increased sleep onset latency, increased VASO, and a lot of sleep fragmentation. All of this contributes to a objectively reduced sleep efficiency, and surprisingly, very high number of patients have a subjective sleep state misperception, also known as paradoxical insomnia. And this arousal threshold has multiple definitions, but I'll stick to the uh, one proposed by this one group, and I'll talk about it in the next slide. So, uh, yeah, just half a minute on this slide. So, most groups have also published that females have a much higher incidence of COMISA. Males may have a higher AHI, but lesser incidence of COMISA. I'm sure most of the experts would also agree. And yeah, so the arousal threshold concept came as not only as a separate endophenotype of OSA, but also an overrepresented trait in all patients with COMISA. And most of these COMISA patients would have less incidence of a collapsible airway. It is mostly this perpetuating arousal, hyperarousal concept. And these are the polysomnography criteria where a lower limit is kept on the desaturation. So 82.5 is what this group proposed. Lowest SpO2 on the overnight polysomnography would be 82%. Anything above is in favor of low 80. Then a ratio of hypopnea upon apnea plus hypopnea more than 58 and a total AHI less than 30. So 2 out of these 3, if they are positive, then it would point towards a low arousal threshold. And I have started mentioning it in my sleep reports because most of these patients run around to multiple pulmonologists saying they have severe OSA. Now their AHI may be very high, but there is hardly any desaturation. Main issue is with the sleep fragmentation, and that is where the therapy also kicks in. Before talking about treatment, we'll spend a few seconds on the impact. So, like Dr. Datta said, the overall impact of COMISA on cardiovascular issues, metabolic issues, mental health, cognitive function, as well as chronic pain is much more than either of the sleep disorders individually, and subsequently their impact on quality of life as well. There is data emerging that there is association with cardiovascular risk. So this group used troponin, cardiac troponin T as a biomarker, where they proved that patients with COMISA had a higher incidence of subclinical myocardial injury. Now I'll spend some time on the treatment. So unfortunately, no formal recommendation or guidelines exist when it comes to COMISA management. There are well-validated therapeutic options for individual sleep disorders. So deciding about what type of COMISA patient you are dealing with is most important. Most of them have a low arousal threshold. So immediately cutting into insomnia would be the safest place to start. And the challenge is, I think some of this is an overlap, but it's a diagnostic delay because sometimes you pick up the OSA and miss the insomnia part. Then adherence is an issue, overlapping treatment issues in terms of balancing and lack of access to a multidisciplinary team. So whenever there is a sleep initiation issue, even if it is an acute insomnia patient and patient has a known history of OSA, CBTI would be the place to start. Usually these patients have chronic insomnia. So CBTI in chronic insomnia is associated with an increase in short-term increase in daytime sleepiness, but eventually it causes sustained sleep improvement. So patient does need counseling, that you will need to do major lifestyle changes, workplace sacrifices for at least a week or two, because most of these patients need some amount of sleep restriction therapy. Unless you reduce their time in bed, the psychological feeling of not having had slept enough always kicks in. Unless they have proven evidence of a severe and desaturating type of OSA on their polysomnographs, I don't even talk about PAP therapy during the first consult. And either doing it the traditional way with a psychologist or doing self-guided CBT with good online audio visual apps and tools is fine. But most of these patients do well, and this was supported by a robust paper where just by doing CBT, there was reduction in AHI. This is again the Sweetman group. The AHI had come down by almost 5 to 10 points in all the patients. These were not even PAPed. So unless there are other endophenotypes, this would be the best approach. In this, lot of data on reduced CPAP adherence. Now, this is mainly because all these low arousal threshold patients will experience a lot of PAP side effects because they will have a higher time spent with the blower on and with them remaining awake. So their subjective sense of the PAP side effects are much higher, and eventually most of them reject PAP therapy. So I usually bring the PAP in during the second or third week. And interestingly, I have seen a few patients where there is a lot of night to night variability. So some of these patients, once we start them on sedatives and CBT, they do not even have daytime symptoms. So a couple of patients, I repeated their sleep study and their AHI actually went down. So the need to PAP them had gone away. There is now data emerging on the role of oral devices. I unfortunately do not have a lot of clinical experience. I would love to hear from the other experts on board. And pharmacology is, I feel, is important, especially in those who have acute to subacute entry points into their insomnia journeys. And the main focus would be on the arousal threshold. However, we do see the odd patient who already has a compromised airway. And now there is some evidence emerging on the role of non-adrenergic agents and antimuscarinic agents where we are suspecting a reduced airway collapsibility. Some of them also have a REM OSA. If you look at their uh, sleep sleep study data, that is also why I prefer a level 2. And uh, all the sedative sleep inducing agents in theory would work. I have also tried the orexin antagonist in some, but somehow the safest place to start, I feel, is melatonin. And this was supported by this recent RCT, where administering 10 mg sedative dose of melatonin had improved PAP adherence. Now, uh, what it did to their AHIs is not revealed in this paper, but all the patients who had melatonin had a better PAP compliance. Uh, I think I have covered all the conceptual frameworks. Now, some of the practice issues which I feel is the patient may not come with a classical history of OSA or insomnia. They may have their own ideas about what is wrong with their sleep. So, even if you objectively prove that they have OSA, they may actually have a very low insomnia severity scale. So, convincing them eventually to go for a PAP is a struggle. Uh, then there are intrinsic issues with all the subjective insomnia scales. Some because of their longevity takes a lot of time, some because of patients' own perceptions. So chronic insomnia patients, primary insomnia patients may continue to have a very high insomnia subjective scale, even if you eventually PAP them, treat their psychological aspects. So uh, these are some of the issues, and I feel that there is a lot of night to night variabilities in these patients. So there was this group, I think Janssen and colleagues had done an acute insomnia study on their patients with OSA, and they proved that 1 or 2 nights of acute sleep deprivation actually was then increased in the AHI. So there were changes in the upper airway collapsibility because of sleep deprivation. So which night's sleep study data would you rely more on is a challenge. So I have started ignoring their AHIs. I focus more on their arousal thresholds, and uh, because PAP acceptance is an issue, and CBT access unfortunately is limited. So doing a modified CBT has become more or less a rule even for me. And another practice issue is once you start PAPing most of them, their PAP devices will not pick up this low arousal threshold related events because they are not taking any cortical sensors. So most patients will come back with a good score on their PAP compliance insomnia symptoms. Daytime symptoms. And unfortunately, most of these patients eventually become gadget freaks. So most of them will buy a smartwatch. They will rely more on the smartwatch data than what actually happens. So uh, I think I can skip the summary slides if you are running late. Do we have a couple of minutes? I think most of it was covered. So I'll just
Yeah, you can run through this slide.
Yeah,
There's no
yeah.
problem.
Yeah, so as high as 30 to 50% patients with OSA or insomnia have COMISA. And these are the patients who have actually a poor self-reported quality of life when it comes to sleep quality, mental health, physical health. PAP compliance is an issue. So managing and identifying the insomnia component very early is actually key. And I feel that we are underutilizing CBT, especially modified CBT that I call, with the help of apps, videos, and even some basic counseling. So just shifting the patient's perspective about what is more important in the long-term uh, treatment goal. And I think sleep clinics are also struggling because pushing out OSA reports, PSG reports has become a rule, but focusing on this insomnia component needs a lot of addressing. And there is a lack of a streamlined guidelines as well. So that also remains a struggle. I think I have covered most of the points. So I would love to hear from the other experts on board. Thank you.
Thank you. Thank you, Dr. Karan. It's a nice presentation and covered almost all the aspects. There still remains, a lot of challenges in this disease diagnosis, and most of the, the reporting and the importance of you checking the arousal threshold in most of these patients, still the difficulty in most of the sleep labs. So, are there any questions?
Do you want to do the questions in the end?
Yeah.
Yeah, let's do the
Yeah.
case, then we
Yeah.
can do questions so that we have a little continuity.
Yeah.
Okay, can you see my slides?
Yeah.
And I assume I'm audible, right?
Yeah, all good.
Super. So let's dive straight into the case. We have spent 30 minutes understanding COMISA, and everybody heard Dr. Karan tell us in his fallout of COMISA slide about the cardiovascular risks and about the cognitive risks. And many of these understandings are often blown over by the lack of great personal experience of how we see patients. And I'm hoping that I can change the way we see about what bad sleep can do to a human brain with this case. So let me share this individual with you. This is a 70-year-old man. He had come to my colleague at the Reliance Hospital with indolent slowing of movements, with some difficulty in arising out of low chairs, and history of noticeable change in his handwriting, saying that his handwriting had become smaller. So when my senior colleague saw him, his clinical exam revealed an asymmetric akinetic rigid syndrome with a significant retropulsion on the pull test and a subtle apathetic change in his personality as narrated by both the patient and his family. So quite rightly, thought that this was an evolving akinetic rigid syndrome, probably PSP, and talked to them about what akinetic rigid syndromes are and the fact that even disorders like PSP may require therapies that augment dopamine in the brain. And he was prescribed levodopa in a dose of about half a tablet thrice daily, ultimately at the end of about 20 days, starting with half once a day in the initial 5 or 6 days with a gradual escalation schedule. Now, when he was started on this very tiny dose of levodopa, a few days later, he was brought to the emergency medical service with escalating disorientation, hallucinations, delusions, and verbal diarrhea. I mean, each of these symptoms were very graphic: disorientation, hallucinations, delusions, and verbal diarrhea. He just wouldn't stop talking. He was convinced that he actually saw his wife having sex with his neighbor, though there was nobody in the room at the time. And he was convinced that his liver and spleen were melting. And he kept pointing when we were in the room that, can't you see, doctor, my liver and spleen are melting and they are coming out of my anus. You can see this pool of flesh on the floor. And he kept reiterating that he was about to die, and he was repeatedly asking his son to organize his funeral arrangement because he said that his time had come. And he was convinced that the nurses, when we saw him in the hospital ward, he was convinced that the nurses were poisoning his IV drip, further reinstating his conviction that he was about to die. And obviously, this is a very dramatic and graphic presentation of a singular change in someone's personality, behavior, and demeanor. There was no history of constitutional symptoms or signs. There were no history of seizures. He had no meningeal signs on the bedside exam. And his akinetic rigid syndrome, to me, appeared a little unchanged from whatever I could see was documented in his clinical notes when he was seen by my colleague. As a result of this very dramatic alteration in his expression and synchronization with reality, his family was shattered, the nurses were distraught, and obviously you can imagine that me as neurologist was pretty vexed because I had no real clue as to what I was dealing with. The family was convinced that it was levodopa that did him in because they kept saying that doctor, this is my father's personality only changed after we started him on levodopa. And he was known to some of my colleagues, other seniors in the city of Mumbai, and they were calling me. And his niece was a neuropsychologist in New York, and she was calling to find out about him. She made a diagnosis of diffuse Lewy body disease for reasons best known to herself. And so we went ahead and investigated him fully because of the drama of his presentation. So he had an FDG brain PET, which only showed mild frontal hypometabolism. A TRODAT was done also, which showed an asymmetric. The TRODAT he already had. Actually, he had done a TRODAT before his presentation when my colleague had seen him, and he had a asymmetric caudate decrease in uptake, in mild decrease in the right putamen. The caudate was on both sides. And we sent his autoantibodies for autoimmune encephalitis because that's what we are geared to do. And this is the age when everybody entertains autoimmune when we don't understand what's happening. We did a lumbar puncture and his CSF was normal. And because we were trying to buy time, I also did a whole body PET CT at the hospital. And it failed to show any occult malignancy or any evidence of focal hypermetabolism anywhere else in the soma. And they are well known to many families in Mumbai. His wife was convinced that there were some paranormal forces at work. You know that when somebody has a strange behavior, we attribute it to supernatural forces. And while I was examining him on the third day, because first 2 days when I saw him, he was fairly alert and dramatically disoriented. But on the third day, the middle of the day, when I was seeing him, he fell asleep in my presence and he started snoring loudly. And there was a prolonged apneic bout while I was auscultating his chest. So here you are. We know that sleep disordered breathing and sleep dysfunction can present in different ways for many of you who were brought up in the times when the Pink Panther series was very popular. For moviegoers like me, you know that Peter Sellers had this penchant for being disguised in different ways so that he would not be recognized. And these are all pictures of Peter Sellers. He actually looks like this. And to me, it appeared as I was wondering whether sleep disordered breathing is also a master in disguise in making the presentation of sleep disordered breathing fairly difficult to recognize to neurologists like us. And so obviously when I saw the clinical signs of sleep disordered breathing, I recommended an overnight polysomnogram for the patient in the hospital. And when I said that and I discussed what sleep disordered breathing means, the wife promptly fished out a 2-year-old study which was done in Breach Candy Hospital for insomnia um, by one of the senior physicians there. And at that time, the Breach Candy Hospital it had shown an apnea-hypopnea index of 65 with very significant desaturation in sleep. And she said that we didn't like the idea of we. I mean, she used the word we. She said we didn't like the idea of sleeping with a mask, doctor, so we ignored this. Though we were told by our physician that he needs to use the CPAP thing. So when he was at the hospital where I saw him, we repeated a sleep study, and I almost, and you heard Karan talk about how not sleeping can worsen your sleep disordered breathing, and when we saw him, his index was 74, and obviously he had slept only in the latter part of the study. And his wife then confirmed that preceding the admission, when I went back and wondered what had he been doing the anteceding days, she said she revealed that he had not slept for almost 3 consecutive days. Now, all of this was very difficult for my students and resident doctors at the hospital to be convinced that everything that we saw in the drama of this man's presentation was perhaps related to his dysfunctional sleep physiology compounded by dysfunctional breathing in sleep. And he was not obese, he was very lean. I have not put in his photograph for reasons in the slide. I don't have permission from him. But he's a very lean person with a retronatic chin, bald head, and he looks a bit like the common man cartoon that you see in R.K. Lakshman's cartoon depiction of the common man. Certainly not obese. So if one looks at what sleep deprivation can do to the synchronization of reality and our ability to interact seamlessly with our environment and self, here's what data seems to show. So this is the paper by Flavie Waters and colleagues. If you have severe sleep deprivation, it can easily trigger in 24 hours visual distortions and anxiety and irritability and a time perception change. If one continues not to sleep for 2 days, it can disorder your thoughts, it can produce depression, and can start inducing complex visual hallucinations like this person. And in 72 hours, auditory hallucinations are not uncommon and severe delusional behavior can happen. So the understanding that sleep deprivation can severely and acutely change the reality perception and behavioral paradigms of human beings. It's published, but how many of us actually in this room ever think about it? And I wondered whether I see many patients with sleep disordered breathing, but this kind of drama was seen only in this individual and one other lady whom I saw later. Uh, and I wondered whether sleep apnea and the insomnia, the comorbid insomnia, did actually induce the psychosis. So we had to put him on melatonin. He was seen by my colleague Kersi Chawda, and he put him on mirtazapine when Kersi saw him to allay the psychiatric manifestations of psychosis and deluded behavior. And we put him on CPAP, and for about gradually over a period of time, he used the CPAP for a short number of days in the initial few days, and then a week 10 days later he started using it longer, and he was fairly good at the end of a month. And at the end of about 2.5 3 months, he actually went for a holiday to Croatia and came back and saw me when he came back. And mirtazapine was gradually weaned off, and he stopped seeing Dr. Chawda, and he could actually tolerate 4 tablets of levodopa, and there was a substantial improvement in his slowness in the bradykinesia of his movements and the rigidity. Um, and we know that Dr. Karan just discussed with you at great length the coinage of the term COMISA by Alexander Sweetman in Australia. And there are now reports of occasional case reports of psychotic depression in sleep apnea, as the one that I have shown you in this slide, and which probably teaches us that there is a lot that we don't know. about how dysfunctional sleep in its entire physiologic construct, with or without sleep disordered breathing, can derange the physiological balance of the brain's functioning in the daytime. So while we often kind of skip over words like cognition and concentration and memory, here's a graphic example of a patient who presented with a whole bit of severe drama. So I also tried to look at the literature as to what do we really know about the association between sleep problems and psychotic symptoms in the general population. So in 2015, there's been a paper in the Journal of Clinical Sleep Medicine that was published from Japan, where they looked at a good number of people. This is a kind of collaborative study in a population-based one in 70 countries between 2002 and 2004, and they managed to only publish this in actually 2015. And they looked at 4 questions pertaining to positive symptoms from the psychosis screening module in the composite international diagnostic interview, and tried to look at its relationship to dysfunctional sleep in and in various populations and countries. It varied from country to country, but there was a very strong association between sleep problems and psychotic symptoms globally. And the point that was being made by the authors, the Japanese authors, is that there was one British author and the primary author was Japanese. And what they tried to imply is that globally, in social paradigm where people are sleeping less and may not know that they have a sleep disorder, this has multifarious implications in functionality, in activities of daily living within families, within workspace, and in society in general. And that must give us some pause to think as to if we don't recognize and we don't address sleep problems, perhaps we are going to have a lot of dysfunctional human behavior that potentially could have been prevented. And that's my last slide. I'm going to stop sharing here and we can open this conversation to questions. Dr. Datta Nagdir is the um,
Yeah,
chairperson for this session. So maybe he can direct the questions and we can take it further. I believe there are about 7 questions in the Q&A.
Yeah. The first question, I think, from Dr. Siddesh. Would you initiate pharmacotherapy first or CBTI in COMISA patients? Dr. Karan?
Karan, the baby is yours.
so he's pulling my legs, so he's my partner. So, yeah, so I'm going to take this again on this stage. So I would initiate pharmacotherapy or CBTI first if I am 100% sure that this patient's issue is sleep initiation. If he is very far along the sleep state misperception, it usually does the initial trick because patients are not going to accept an OSA diagnosis right away. If they are walking in with this subjective perception that my problem is I can't sleep, if they do not have daytime symptoms, then no point papping them. First sort out their
If they go completely cuckoo, you can actually put them on PAP.
yeah. So most acute insomnia or acute on chronic insomnia who have a clear-cut induction issue, not worth papping them, not even discussing importance of PSG right away. But they usually come back with an expected side
No,
effect.
he's asking about medications before CBT.
Yeah. So okay. So uh, there is always going to be some amount of CBT that you do on every consult. You cannot do an ideal CBT for all your patients. You eat away 1 hour. So I spend the time on sleep hygiene, at least sorting out some sleep efficiency. So if they are trying to oversleep, so reducing the sleep time, and to improve induction, I would at least do some sleep induction measure. So both. My answer would be both.
Oh, absolutely. I think this is a very individual approach, and I don't think anything is right or wrong. It all depends on how you see the acceptability with which the patient's going to listen to the sage advice that you think you are giving them. And for many, it may need medication, which could include melatonin and maybe a somnolent as well, in order to allay their anxiety about how they're going to sleep. And in conjunction with that, they have to be counseled about CBT and made to understand that it's behavior that garners sleep health, not not a chemical push into the brain. And then over time, if this dysfunctional breathing also needs addressing, one can take it. So I think it's a very stepwise individual thing, and I don't think there is a straight answer to every patient.
Yeah.
I think next question, I think, was this patient tested for Eglon 5?
Sorry?
Was this patient which you presented tested for Eglon 5?
Yeah, IGLON
And,
5 was negative. All the autoimmune, we do IGLON 5 in all our
Yeah,
patients
yeah.
who
That
have
was
an akinetic rigid syndrome and disordered breathing.
yeah.
I already have 3 patients whom we have shown in meetings, including
Yeah.
their videos, and some of them have been shared by European faculty too. But we do IGLON 5 in all our patients.
Yeah. One question from Dr. Sindhu. I think in all insomnia patients, should we do PSG? Except obesity, any other patient factors in history or examination, would you consider doing PSG? Karan would like to answer this question.
yeah, so I would definitely screen very aggressively. But like I said, if the patient is fixated on induction and maintenance issues, then as a footnote during that consult, I would sensitize them that this is also a possibility. And I think obesity is misunderstood. So it is more of the craniofacial features, the Malampati airway snoring symptom, which usually alerts you. So you know that it's there, but the patient is not ready to accept that answer. So
Yeah,
So
exactly.
let me also pitch in here. My apologies. Um,
yes, sir.
it's an important thing that that person's asking. I think we need to integrate our clinical senses into understanding what are the pathways that lead to sleep disordered breathing. So if my patient has a long-standing history of smoking, even if he's given it up, if he consumes alcohol frequently, and he says that they often he or she, if they have alcohol in the evenings, like most people after 8 p.m., if they need not necessarily be obese, but if they have a history of 1 or 2 systemic factors like hypertension and diabetes, and if they are over the age of 60, I would certainly have no hesitation in doing a polysomnogram, because I really want to know not just how they're sleeping as a very crude construct of how they feel they're sleeping, but I really want to know, do they have good sleep acquisition, both deep sleep and REM sleep? How do they actually breathe? What's their arousal? How often they are waking up? And what is their real oxygenation? Because
Absolutely.
beyond 60, all of these things are going to be a determinant of every organ that uh, is vital for basic health. We did a study in Jaslok with one of our nephrology colleagues where we screened patients with CKD, with sleep studies, and every one of them consecutively as a DNB thesis for with PSGs and a sleep history. And you'd be surprised that 57% actually had moderate or severe sleep disordered breathing.
Yeah.
Yeah.
So,
I think there's one question about the CPAP tolerance and the despite optimal machine settings, patient is unable to tolerate CPAP. I think this situation is very common when the patient is started on CPAP. Many times they feel little uncomfortable, but it's just we need to spend some time, counsel them, and make some necessary adjustment in the mask. Most of the patients will tolerate.
Yeah, so there's
Yeah.
one more angle to this, and I work with some of my ENT colleagues too who are interested in sleep, and unfortunately, Dr. Agarwal is not here today with us. I think he's tied up elsewhere. But there is a role, especially in older people. If older people are optimally titrated and they cannot tolerate the PAP device, they need to be screened for a drug-induced sleep endoscopy. And many a time, we don't know much about the finer nuances of geriatric sleep disordered breathing. And when I say geriatric, I mean a little above, close to 70, 75. Anyone who's 70, 75 and is struggling with a PAP device, it may be worthwhile to get an ENT valve from someone who knows about this. And the standard of care is to do a drug-induced endoscopy and to figure whether there is a lateral collapse or even a velum collapse. And sometimes the epiglottis collapses and closes the orifice, the airway. And they may need a surgical intervention by the ENT surgeon. So there are many in the country who are looking at this, but in Bombay there are just a few I know. There is a very big project on this subject in at PGI in Chandigarh.
Yeah, I think most of the questions have been answered. Yeah, then almost all.
So I think the geriatric sleep disordered breathing is going to be a big challenge, because a lot of people have gone through life accepting mild or moderate suboptimal breathing and muscle tone and sleep hygiene all as a heady cocktail, which is not making them optimally restored, and they've taken it as just aging, or this is who we are. This is how, perhaps this is what aging does to us. I mean, what do you expect? We are older people. We've all been taught that as you grow older, you need less sleep, and that probably is a myth. But very difficult to bust that myth.
Yeah.
And I think our concept of the older people will change. There's a lot of work to be done.
Yeah.
And I'm so happy today that we had 56 participants. It's absolutely heartening. And I must take this opportunity to thank all the participants, the attendees who have taken time off from their busy schedules and decided to be here. Thank you very much for being here with us in order to share and understand thoughts, ideas, and notions about sleep and its value in human health.
Thank you.
Great.
Thank you. I think.
So thank you.
Yeah.
Thank you, Dr. Datta, for being here. Very nice to have you. Karan, brilliant job. Thank you so much. And Bhavesh, Asmita, do we have anything to say, or can we close the meeting?
I think we can. Yeah, I think that's it.
Okay, super. Thank you, everybody. Thank you, everyone.
Thank you. Thank you. Good night.
Good night.
Good night.